Thank you all for being here today. I hope you enjoy the kind of two-thirds carbs lunch since we'll be talking about gestational diabetes. Do we know why we call it gestational diabetes? It's very simple. I'm not trying to be... Yeah. So, what did I hear?
Happens during gestation.
Yes, with a patient or a woman who have no prior diabetes, right? So it just shows up in pregnancy. So it's glucose intolerance with onset or first recognition in pregnancy that is not clearly over diabetes. And that both agrees, both the ADA and the ACOG, which is the American Academy of Obstetrics and Gynecology, American Diabetes Association. So what happens, the physiology in pregnancy, typically we have increased pancreatic cell hyperplasia, increased fasting, and postprandial insulin level. But in the third trimester, that's why we see it and we screen for it, around 28 weeks, 24 to 28 weeks, is that there's increased secretion of placental hormones, and they play a part in increased insulin resistance. That's why you see it more so in the third trimester. And gestation diabetes occur when the beta cell function is insufficient to overcome this insulin resistance. So prevalence, there's about 6% of pregnancies in the U.S. Affected by GDM, but it could range up to 25% and really depends on the population and how much screening you're doing. And the prevalence is increasing, and it has, definitely health implication of both mother and baby. So what is the risk factors for gestational diabetes? Like any other illness, you hear preterm labor, prior preterm labor, right? Gestational diabetes, prior gestational diabetes. Body mass index of more than 25. So how many of our patients are 25 and less, right? We are, right, in that population. Ethnicity, Asian, Native American, Pacific Islander, Black, Hispanic. You don't see Caucasian, and this is all from all studies. Caucasian were excluded, but if they have other risk factors, it doesn't mean that we don't screen. There was a time where they didn't screen Caucasian because of that low risk, but I think universal screening is much better. Diabetes in first degree relative, weight gain more than 11 pounds since 18 years old. I know, who didn't gain that weight, right? Maternal age older than 35. Gestational weight gain in excess of Institute of Medicine guidelines, and that will be the next slide. And macrosomia in previous pregnancy. So, how much do our patients need to really gain weight? What's the recommendation? Look at this. If they're under 18 BMI, the recommendation is 28 to 40. And, 18.5 to 24 is 25 to 35. 25 to 29 is 15 to 25. And more than 30, which is most of the population, 20 is the max. So we need, just keeping that in the back of the mind, reassuring moms that they don't really need to gain too much weight. Don't worry if you're not gaining weight, especially those with the kind of obese level BMI. I'm sorry, kind of like this is from the ADA, but we'll take it in pieces. It kind of summarizes a lot of good information here. So, woman at risk factor. Test for undiagnosed type 2 at first prenatal visit using standard diagnostic criteria. How many of you guys, as you're doing, so the first visit comes in and you do past medical history, family history, social history, you look at the vitals, you look at the BMI, and I probably should screen her for diabetes early. Anybody of you have encountered this or had a discussion with us about it? So there is such a thing. There is such a thing And keep in mind those who are also have PCOS. So what we're trying to do in the first trimester screening for just diabetes is really to look for type 2 diabetes. This is not the intention for gestational diabetes. This is the intention to find those who are undiagnosed, so pre-gestational diabetes. Because, why is that important? Because they have higher risk factors, right? More and more follow-up, more intense follow-up. And those without known of prior diabetes, test GDM at 24. So those who doesn't have the risk factors, so then you start between 24 and 28. But why do we pick 28 to do it most of the time? Is it wrong to do it at 24 or 26? We pick 28 because we're doing the other labs, right? The HIV, syphilis is really at 28. It's have to be at the third trimester. So we pick 28 to do all so they can get one blood draw. But you can do it anytime if you have a suspicion for it around that time. So now we know she have gestational diabetes. What do we do with her care? When she comes back for her postpartum visit, the recommendation is to do an oral glucose tolerance test. That means the 2-hour glucola that we used to do, not the 3-hour. Now she's not pregnant, we do the 2-hour glucola. That's the standard, but have you ever had a woman have that much time when she's postpartum to come and sit down for 2 hours and do it? I wish really that they would change this, because you can see through the other thing you can do is a fasting blood sugar if they're fasting. Sometimes I throw a random, if I do a random, if they just had a food, I can gauge things from it, or an A1C, if it's far enough. Women with history of GDM also, remember, they're now diabetic, lifelong screening every 3 years with the A1C. History of GDM and pre-diabetes, they need lifestyle intervention or metformin for diabetes prevention. Women with diabetes in the first trimester, we're talking about type 2 diabetics. We're not talking about GDM. Now it's pre-gestational. And GDM is diagnosed in the second or third trimester, which is not associated with type 1 or type 2 diabetes. So how do we screen? So the ADA recommends a woman at risk, which we mentioned the risk, should have early screening at the first antenatal visit, so-called early screening, using the ADA diagnostic criteria for non-pregnant adults. Those women BMI 25 or greater, plus any risk factor, physical inactivity, relative with diabetes, high-risk ethnicity, previous GDM or hypertension. So these are what you're going to gauge, okay, who I'm going to screen. So that's when you have the first visit, you're kind of looking at risk factors, and gauging and asking for the first trimesters, performing the first trimester screen. For the U.S. Preventive Task Force, they recommended asymptomatic pregnant women be screened for GDM after 24 weeks. The recommendation. Most, but not all, U.S. guidelines favor the 2-step. So this is what we do. We do the 2-step. And what is the 2-step? Is given the 50 grams of the glucola, the drink, right, whether orange or banana, or what do they have? I think orange and banana. They both don't taste very well. I had a lady today took it and she started vomiting. So I had to bring her in, lay her back, and give her a bassinet, so to help, But I don't, in the past, the lab used to send them home. I said, please don't send them home. If they vomit, I can't perform it again. Bring them over, we can have them lay down, we can help them. It's just 1 hour and get the blood and they can go. Or in Europe, they do the 1-step, which is the 75, which is the one we do for non-diabetic, the woman with no diabetes or anybody for screening. Optimal screening approach is controversial. Which one of this? So if you're in a place and you didn't have the 50 or the 100, you can do the 75. Just, open your mind that we can do that. And then increased glucose level. So if you had one abnormal level, that there is risk of adverse pregnancy outcome. And no trials have demonstrated that treatment of GDM in these women improves outcome. But even having one abnormal in the 75 can increase risk of pregnancy outcome, bad outcome. So more about the 50 gram. What do you think? Which one is the threshold? Is it 130, 135, or 140 for the 1 hour glucola?
40.
Typically we do 140, but you can do 130. You can use 130 or 135. In the OBGYN department, they use 135 as the threshold. But you can go down all the way to 130 and then do the 3 hour glucola if you have enough risk, if you're concerned. Engage, like she's probably gonna, she looks like she might, I don't think we're good at that yet, but there is room to screen even if they're at 130. Like I said, the OBGYN, they use the cutoff for them is 135. We do 140. So cutoff of 130 is more sensitive. It's 99% versus 85, but less specific compared with a cutoff of 140. And then you have 140 to 200, less or 200, you can do. So when they're between 140 and less than 200, you can do the 3 hour glucola. What if the lady came back with a blood sugar of 180 on the glucola? So in between these, but not 150 or 160. Let's say it was 180 and up. Have you noticed any notes there when the comes back? So the lab, our lab, have a little note there. Anybody had the chance to have somebody with that level? So the lab tells you if it's 180 and up, you do not need to do the 3 hour. So you can save the 3 hour because we know it's high anyway. So then you can actually reasonably skip the 3 hours. So it is reasonable to treat these patients empirically as if they have GDM without performing 100 100 gram or glucose tolerance test because they require insulin. They will require insulin during pregnancy more often than the patient with GDM diagnosed using the 100. So they're high suspicion of having gestational diabetes. Yeah. So what are you going to do next? I mean, am I going to stop? No, you're going to say your levels are high. We're going to send you to get nutrition counseling, and we're going to teach you how to check your sugar. So you treat her as if she's GDM. Any questions about this? So there is 2 criteria for the 100 gram of oral glucose tolerance test. We follow the Carpenter because you can see there's a little bit of a difference. They kind of give more room. Not much higher, but we go by the Carpenter and Houston criteria, which is fasting 95, 180, 155, and 140 compared to the National Diabetes Data. We go more with the tighter, with the more tighter or strict. So screening, the 1 step, like we said, is the 75, and it's in the morning. They have to be fasting for it, more at least 8 hours. Repeat test at 1 and 2 hours after initial measurement. So they do fasting and they repeat it in 1 hour and 2 hours. So they have 3 numbers to look at. While the 1 step is it's the fasting, and then they do the 1 hour and 2 hours. For a treatment, why is it important to treat? Why is it important even to diagnose and treat? Because we know there is adverse effect on the mom and the baby. So So they did a study, there's a large study of GDM, a trial of GDM treatment. Investigators randomized about 1,000 women with GDM to no treatment or intervention. Intervention included lifestyle modification, self-glucose testing, monitoring, insulin therapy if needed. It depends on the results. And what was the adverse outcome they were looking at is infant death, shoulder dystocia, fracture of the bone, and or nerve palsy. They found that in the no treatment group, 4% were the adverse outcome compared to 1% in the intervention group. So intervention does help. More recent systematic review and meta-analysis included a randomized controlled trial, and about 5 of them and 6 cohort studies found that treating gestational diabetes resulted in statistically significant decrease in incidence of preeclampsia, shoulder dystocia, and macrosomia. And you guys, you all seen macrosomic babies, right? This is just a reminder if you haven't seen one. Okay, so how do we manage? Management is lifestyle modification. So we're sitting in the clinic, right? We're right there, patient is right there. What are we going to be talking about? We don't have a monitor yet, right? So we have to talk about things. We're going to talk about diet and lifestyle modification, activity modification, blood glucose monitoring, how often, medication management if needed, intrapartum management, postpartum management. All this is going to be included under the management treatment of gestational diabetes. So how often do they need to check their sugars? Do we know?
I think ideally like 4 times a day, but that's a lot to ask, I know, but like a fasting in the morning and then 2 hours postprandial after each meal.
I think it's reasonable to do that, at least to have a gauge where we are, just like we do with any diabetic, right? More about diet changes, limit this is the key, is really limit your carbohydrate to 33 to 40% of calories. No high quality data exists on the optimal diet for a woman with gestational diabetes. Cochrane review of 9 small trials comparing different types of dietary advice did not demonstrate any significant difference in perinatal outcome. Some trials suggest that low glycemic index diet may result in improved glycemic control. So it's all really about the sugar and glycemic index. This is a big list. This is not intended for you guys to read, but this tells you that how much the dietitian can go over in regard to diet. So what about sweeteners? Most women like, so can I use sweetener? Is there a yes okay for one type? Is there a no for other type? Chi-chi? Yes, saccharin is strongly discouraged during pregnancy because it crosses the placenta, but we have other aspartame, and I can't name that, you guys read it, is okay. At least aspartame. Then maternal weight gain. Like we said, we mentioned what is the ranges of maternal weight gain. But we know that if we have a woman with obesity and GDM, and she's gaining weight during her pregnancy up to more than 40 pounds, the risk of fetal macrosomia is nearly 40%. So that's a way for us to, that's another way to encourage us to encourage them not to gain weight. So we have a number to share with them. There's a 40% chance if you're gaining weight, if you're gained at least more than 40 pounds, that you have a chance of having a big baby. And no specific intervention has been shown to prevent excess gestational weight gain. I did not know that.
Thank you, Mother.
Is it by wave? Did I wave?
No, I just cut off
It's been
now.
doing this a lot.
Yeah, we need to replace that thing.
It's pretty new.
That's a new one?
$20,000.
So big.
Yeah.
It's new.
Wait, when was it purchased? Like a year and a half.
Within the last 3 years.
Should be might be under warranty.
I think we need to check people out.
We need to projector like half that size.
Okay, while we're getting this fixed, let's talk about what is the numbers. We asked the ladies, they say, what numbers are we want them to keep their sugars at? Let's do fasting. What numbers you want them to be at fasting? Less than what?
I think around 90.
Yeah, I heard good. Yeah, around 1995, right? For gestational diabetes, 95, less than 95. What about the 1 hour?
180?
There's 1 hour and 2 hours, okay?
Oh, I don't remember one. I think 2 is 120.
Thank you very much, appreciate it. So as you see, for GDM is 95, but I just gave you, I also added the pre-gestational just to have an idea what's the difference if she was diabetic versus if she was just gestational diabetes. So 95 for fasting compared to 90. 1 hour, some women will check a 1 hour glucose. Let's say she said, the only time I can do it is 1 hour after I eat because I'm at work. I cannot really stop after 2 hours. And then you can have her do the 1 hour. 1 hour is 140. This is one stricter, 130 to 140, 120 and 120. It's almost the same, just a little difference in the fasting. A1C to keep it between 6.6 to 6.5 is recommended. Less than 6 may be optimal as pregnancy progresses to achieve if there is no hypoglycemia. Any question about the numbers, guys? I think you know it. I can tell the minute you said 95. Okay, so glucose monitoring is no data suggests the superiority of doing 1 hour or 2 hour postprandial monitoring. Either is acceptable. Less intensive glucose monitoring is appropriate for women with GDM, is well controlled with diet and exercise. So, like you said, I don't want to overwhelm them with it, but if she's controlled with diet and exercise and she checks a couple of times, I think, and it's doing well, I think it's fine. So for pharmacological therapy, when do we decide to start? So she's coming in, she's bringing her numbers, right? When do we start medication? When blood glucose definitely increased, despite what she's doing, diet and exercise. There's no consensus exist on the threshold value above which medication should be prescribed, but consider the gestational age, frequency, and severity of blood glucose elevation, fetal growth, and patient preference. And this will help us okay. So when do we begin the pharmacological therapy? If you're looking at a 2-week period, if you ask them to come back, if you're expecting that she's going to be high, I'll bring her back in 1 week. If you think she's going to be high and she's going to need medicine for sure, bring her back in 1 week, and if 50% of values are elevated, then you start treatment. If you don't think she's going to be quick getting into medication, you can bring her back in 2 weeks, and then if more than 2 values at the same meal are above target by more than 10 milligram per deciliter, then you start medication. So this is how we base starting medication. I think when I started, I didn't know when do I start medicine, but I felt this was helpful to know when do I feel more confident when do I start medicine.
When you say at the same meal, do you mean like she
Some
had
of
lunch
them-
2 days after lunch she was high?
Yes,
kind of thing?
yes. And some of them will have only breakfast will be high, or lunch will be high, or dinner. And then that's when I probably will start oral medicine, and that's when I decide when is the peak of action to help with that meal. Small baby doses.
So if breakfast was high and then dinner was high,
Then it could be any time. Yeah,
would you start medicine then? Or?
yes,
Okay.
yes. I'll start a small baby dose of laboride.
Okay.
And nowadays, we can do metformin. So there is insulin or oral medication. The difference between them, this is the standard historically before we started doing medication. Now medication is considered as a first-line therapy too. They are the same in regard to glycemic control, maternal neonatal outcome, and adverse effect. The only thing with oral medication is 15 to 40 of women initially prescribed oral medicine would ultimately need insulin. But it's okay to buy time because, you know, if it's safe, because, you know, injecting someone is not a fun thing to do. Any questions about this? So the oral medications we have is metformin and glyburide. They're both not approved by FDA. They both cross the placenta. They both not associated with birth defects or short-term adverse outcome. They both lack long-term safety data. We start metformin at 500 once a day with food and titrate to a maximum of 2,500 milligram per day. Could be given in divided doses. And for glyburide, we start at 2.5 once per day, 1 hour before food, and increase to maximum of 10 twice a day as needed. Glyburide will possibly have lower failure rate than metformin. So more failure rate, more need to go to insulin than the glyburide. So for insulin, it's used with uncontrolled blood sugar, despite we're doing oral, we're doing lifestyle and diet changes. It does not cross the placenta, considered safe for the use in pregnancy. So just how do we start insulin therapy? It's really the same idea as non-pregnant. So you calculate the daily requirements, giving her about 0.7 to 1.0, and I always remember Dr. Kirk, if they are insulin naive, start with a lower, right? So start with a lower, and then you can divide it in half. We have the long-acting insulin, and then we have the meal, 3 divided doses of the fast-acting. Insulin dosing should be individualized, but sometimes just one would be enough. Just the baseline could be enough for them. The less shots we give, the more happier the woman would be. How do we assess baby? So there's really no consensus about the optimum way of doing monitoring for the baby. Don't forget about kick count. Kick count is very valuable because it could trigger us to do testing, but it's all for the sake of happy, healthy baby, healthy mom. For well-controlled, without medication, there's beneficial. It's not beneficial because the risk of stillbirth is not increased in this population. Those who require medication, you want to do antenatal testing. Data supporting this practice are limited to older observational data. ACOG recommends that clinicians perform antenatal testing in accordance with local practice. So whatever our colleagues are doing or encouraging, we'll say that kind of try to be on the same page. And such testing could be like twice weekly non-stress test, or with weekly BPP, starting at 32 or 34 weeks gestation. Probably with insulin medication, you may start at 32, medication you may start at 34 or. Ultrasound role in GDM. The role of ultrasound varies among, clinician institutions. Some physician will get every 4 weeks to monitor baby growth. And several small trials found that if accelerated fetal growth, then tighter glycemic control may result in lower incidence of large for gestation life. So it will help with this population who you can see that the baby is really the percentile, right? We always look, 90 percentile baby. Those we can tell them maybe tighter glycemic control to avoid baby growing more. So it will help with that population. Larger studies are needed more to do this as a routine for management or GDM. because third trimester ultrasound always independent risk factor for cesarean delivery. Now, can find more bigger babies, can lead to more C-sections. Some physicians will perform ultrasound near the end of pregnancy to assess the risk of fetal macrosomia. If you have a baby, weight by ultrasound is about 8 pounds 13 ounce or more than 400 grams, is only modestly predictive of an actual weight, with a positive likelihood of 5.7 and a negative likelihood of 0.48. I know you like these numbers, guys. They like these numbers, yeah. Macrosomia prediction, baby weighing more than 4,000, clinical estimate using the Leopold's. Remember, like, Dr. Namak, so what do you think her weight is? And we're like putting our hands right and trying to do the weight by Leopold's and fundal height measurement are predictive of macrosomia as ultrasound and appear comparable to the estimate of the baby size. ACOG recommends that clinician assess fetal growth in patients with GDM in the third trimester, stating that ultrasound or clinical exam is appropriate. So how are we going to deliver that baby? And when do we decide to deliver the baby with a GDM? Any ideas? Any thoughts? If she's controlled and doing well, do we have to rush to induce her? I like the shaking no. I like it. So yes, really depends on the risks for that lady. Given neonatal risk with early term births, so we don't want to induce early because there is still risk from early prematurity or early, what's that, the new term about when they're term, but they're early term, they're not like full term yet. Yeah. So less than 39 weeks, only if glycemic control remains poor. So she's taking meds, we're still having spikes. We want to get that baby out because there is a risk of really stillbirth. Limited evidence suggests that induction of labor at 39 weeks compared to expectant management is associated with low risk of macrosomia and shoulder dystocia without increasing risk of cesarean delivery. Expecting management more than 39 is associated with increased risk of stillbirth. The relative risk is 1.8, although the absolute risk remains low. I had one lady which was diagnosed with gestational diabetes, and she required insulin, and she had a prior C-section. So the plan for her is to have another C-section. And she presented to triage, like on her C-section was on a Monday, and it was like I think they had her around 38.5 weeks. But she came in on Friday or Saturday with decreased fetal movement. The strip was good. She had one variable, but then the strip was beautiful. She was sent home. Monday when she came in, they tried to find the baby heart rate. It was not there. So, really, really important. Paying attention to fetal movement, checking T cells, it was very unfortunate. I got to deal with her afterwards, I definitely got a call from the OB saying this shouldn't have happened, and I agree with her, but who would know? She also took marijuana. She was marijuana positive, so I don't know if that kind of played a role, but her sugars was in the 200s. Yeah, it was difficult. But so I always remember her because stillbirth is scary. It's scary, and it's real. It's real. Even with gestational diabetics is a concern, and with gestational diabetics uncontrolled. The way I express is that I learned shoulder dystocia maneuvers is from pulling how many stillborn babies from Iraq, because Iraq, it's a third world. Nobody checks for, no screening. We didn't have screening. We know there's diabetes, so they come into the hospital. We keep them there until they deliver. But those women who are outside, who haven't had care, they would come in with a stillborn. They come in because there's labor, and then there's no fetal heart. So I learned, because that baby gets macerated, and to pull it in one piece is important for the family. So I learned so much, all my maneuvers as to pull it, because I was trying to get that baby out gently without making it tearing. Okay, so timing and route of delivery. ACOG had not made any, has not made an evidence-based recommendation on ideal timing for delivery. Many physicians will offer induction of labor at 39 to 40 weeks, particularly for patients with other risk factor for stillborn. For women with GDM, an estimated weight of 9 pounds 14 ounces, you actually can discuss cesarean delivery with them and schedule cesarean delivery. You have to talk with them about the risk, of either or, like letting them go through labor with brachial injury, dystocia, all that stuff. And they found that scheduled cesarean delivery compared with vaginal delivery decreased the risk of permanent brachial plexus injury with the number needed to treat, about 588. It is reasonable to offer, like I said, cesarean delivery, but you have to counsel them about it. So when she's in labor, have we ever used insulin on our patients with GDM in labor? You guys remember using insulin? We've never really used insulin, right? It's really those who are on insulin, they probably will need insulin. But we want to maintain euglycemia, decrease risk of neonatal hypoglycemia and acidosis. For diet control, they require really nothing that we know of them requiring anything. For women receiving insulin, there's a variety of protocols. So if you've seen, I've looked at protocols. We have a very nice one. And you guys, when you did probably high risk, you maybe came across somebody with pre-gestational diabetes or GDM on insulin. And we do the glucose. There's a protocol. They monitor glucose 1 to 2 hours during active labor. They use 5% dextrose or insulin infused as needed to maintain glucose level between 70 and 110. So that's the range you want to keep it in. It's reasonable to use only half the usual dose of long-acting insulin at the day of the delivery, just like we do for surgery, right? We send people who say, take half your dose before, right? We don't want them to not take anything, but it's reasonable to do half the dose. Prepare to manage shoulder dystocia and time of delivery, and exercise caution when considering an operative vaginal delivery. So if you have a big baby and you may want to think of cesarean delivery and really not going through vacuum or forceps and then ending up with a shoulder, so you have like double, triple trauma. For postpartum management, I know it's a long slide, but I have a lot of information. Rarely there's a need for any oral, so when they're done, they have a baby, do we keep continuing to write down for them metformin or glyburide, or no, we don't? Well, it's wise to check a sugar just to see if they're back to normal. And it's wise also to consider like a short and long-term follow-up for how's your sugar. Just check it a couple of times at home. And then we screen. The recommendation is screening. We can do a fasting sugar measurement or the 2-hour glucola, and we already said that. Who's going to come and sit for 2 hours? Postpartum, have a baby, they're already tired. Up to 36% may have persistently abnormal glucose tolerance. GDM is a significant risk factor for subsequent development of diabetes. In high-risk population, it's about 50% of women from GDM may develop diabetes in the next 5 to 10 years. And then, so screen every 3 years for over gestation diabetes. Breastfeeding may reduce the subsequent risk of developing type 2 diabetes. So, encourage them to do that. Any form of contraception, unless there's other risk factors, is to hold in one type and use the other, or choose, it's okay for them. I remember I had one lady with gestational diabetes, and her daughter now is like 6 or 7, and now she's diabetic. So it is true. They will, that's between, for her it was like between 5 and 10, she developed diabetes. But we kept checking, the A1C because of her risk of gestational diabetes. This is very long. You guys, if you want to read it on your own, this is the key recommendation. There's the B, what's that, the evidence rating recommendation. It's 1B and all others are C. But the B one is screen for GDM 24 weeks in all women without known diabetes mellitus. These are the references. It's from AFP and from AD, American Diabetes Association. I thought that was cute. Thank you. So now we're all ready and set for gestational diabetes?
Yes.
Any questions, guys? So diabetes made simple, right? Made easy. Okay. Thank you.